What if the real problem was never in the bedroom at all, but in your bloodstream? That's the question a growing number of researchers are asking. And the answer is changing the way we think about male sexual health entirely. Because here's something most men have never been told. An erection has almost nothing to do with willpower, mood, or even attraction in the moment. It's a plumbing problem, and plumbing problems have plumbing solutions. Stay with me, because by the end of this, you're going to understand your own body in a way that most men never do. Let's start with a quiet statistic that rarely makes headlines. By the age of 40, a significant percentage of men will experience some degree of erectile difficulty. By 60, that number climbs even higher. And yet almost none of these men ever talk about it, not with friends, not with partners, sometimes not even with their doctor. It gets absorbed silently, treated as a personal failure instead of what it actually is, a measurable, physical, and often reversible health signal. That distinction matters more than anything else in this video, so let's sit with it for a moment. A struggling erection is not a verdict on your masculinity. It's data. And like any data, it can be read, understood, and in many cases, improved. So, where does that data come from? To answer that, we need to go somewhere most men never think to look, the inside of a blood vessel. Picture the arteries feeding blood to the pelvis as narrow highways. When everything is working correctly, a surge of nitric oxide, a molecule your body produces constantly, tells the smooth muscle lining those highways to relax and widen. Blood rushes in. Two internal chambers called the corpora cavernosa, essentially spongy reservoirs of erectile tissue, fill up and expand. The pressure of that filling is what creates rigidity. It's elegant, it's fast, and under normal conditions, it happens almost automatically. But here's the part that surprises most people. This exact same mechanism, nitric oxide, arterial flexibility, unobstructed blood flow, is the very same system responsible for a healthy heart. Your penis, in many ways, functions like an early warning system for your cardiovascular health. Some researchers have gone as far as calling erectile difficulty a possible preview of future heart disease, sometimes appearing years before a cardiac event shows up on any test. That's not meant to alarm you. It's meant to reframe the entire conversation. This isn't just about performance. It's about circulation, and circulation is something you can actively influence. Now, here's a misconception worth clearing up immediately. Many men assume that if the mind is willing, the body should simply follow. But arousal is only the trigger, not the mechanism. You can be fully attracted, fully in the mood, and still experience difficulty if the underlying vascular system isn't cooperating. This is why performance anxiety and physical vascular issues often get tangled together, each one making the other worse. A man who experiences one disappointing episode may start to worry before the next encounter even begins. That worry releases stress hormones like adrenaline, which constrict blood vessels, the exact opposite of what's needed. It becomes a loop. Physical cause, psychological reaction, physical worsening. Understanding this loop is often the first step toward breaking it, because once you know the difficulty may be circulatory rather than purely psychological, some of that pressure quietly lifts. There's another factor hiding in plain sight that almost nobody discusses, and it's called disuse atrophy. Just like a muscle that isn't used begins to shrink and weaken, erectile tissue that goes long stretches without blood flow can lose some of its elasticity over time. In more advanced cases, this can contribute to fibrosis, a stiffening of tissue that makes healthy expansion harder to achieve. It sounds unsettling, but the takeaway isn't fear, it's function. The body responds to demand. Tissue that's regularly asked to fill with blood tends to stay more responsive than tissue that isn't. This single insight is the foundation for almost every evidence-based rehabilitation approach in this field, and it's exactly why the two methods we're about to cover exist in the first place. The first is something that sounds almost too simple to matter, and that's exactly why most men dismiss it. It's called pelvic floor training, and if the word Kegel makes you think of postpartum recovery classes for women, you're not wrong, but you're only seeing half the picture. Underneath the pelvis, stretched like a supportive hammock, sits a group of muscles that most men have never consciously felt in their entire lives. One of them, the pubococcygeus, sits directly beneath the base of the penis, and it plays a far more active role in erectile rigidity than most people realize. When this muscle contracts, it compresses the veins responsible for trapping blood inside the erectile tissue. In simple terms, a stronger pelvic floor means better blood retention exactly when it's needed. Finding this muscle is easier than most men expect. The classic method is to briefly interrupt your urine stream. The muscle that engages to do that is the same one we're targeting, though this should only be used as a one-time identification test, not a regular habit, since doing it too often can actually interfere with healthy bladder function. Once you know what that contraction feels like, you can practice it anywhere, seated at a desk, lying in bed, waiting in traffic without anyone around you having the slightest idea. A typical approach involves contracting for a few seconds, releasing for the same amount of time, and repeating this in short sets several times a day. Clinical research on pelvic floor training for erectile difficulty has shown measurable improvement over a period of weeks in many participants, particularly in cases described as mild to moderate. It's not an overnight fix, and no serious researcher would claim otherwise, but the fact that a muscle most men have never trained can meaningfully influence something this significant tends to change how people think about their own bodies. What makes this approach particularly interesting is what it does beyond erectile function. The same pelvic floor muscles are involved in ejaculatory control, urinary continence, and even core stability. Men who train this area consistently often report a broader sense of physical awareness in that entire region of the body, an area most men go their entire lives without ever consciously engaging. There's something almost humbling about that. A part of the body responsible for so much daily function, sitting completely untrained, simply because nobody ever taught us it existed. Now let's shift to the second approach, and this one operates from the outside in rather than the inside out. It's called vacuum erection therapy, and despite sounding like something out of a hospital brochure, it has a long and well-documented medical history. Originally developed to help men recovering from prostate surgery regain erectile function during the healing process. The device itself is straightforward, a cylinder that fits over the penis, connected to a pump that removes air, creating negative pressure. That pressure draws blood into the erectile tissue, producing an erection through mechanical means rather than the body's natural neurological trigger. Here's a detail that even some men who've used these devices don't fully understand. The blood drawn in through vacuum therapy is primarily venous blood, meaning it carries less oxygen than the arterial blood involved in a naturally triggered erection. That might sound like a downside, but the value isn't in replicating a perfect natural erection every time. The value is in what repeated stretching does to the tissue over the following weeks and months. Regularly expanding the corpora cavernosa through mechanical means appears to encourage better tissue elasticity, improved oxygenation over time, and according to some studies, even supports the vascular remodeling process, essentially retraining the tissue to respond more readily on its own. A typical protocol involves short sessions, somewhere in the range of 15 to 20 minutes, used once daily or every other day depending on individual tolerance and manufacturer guidance. Like any therapeutic tool, more is not automatically better. Overuse or excessive pressure can cause bruising, skin irritation, or in rare cases more significant tissue damage, which is why following the specific guidance that comes with a given device matters far more than trying to accelerate results. Some devices include a constriction ring designed to maintain rigidity after the pump is removed, useful in certain contexts, though many clinicians caution against extended use of these rings due to the risk of restricted circulation if left in place too long. The tool is designed to be a training aid first and a temporary solution second, not the other way around. Interestingly, vacuum therapy is often used alongside other treatment approaches rather than as a standalone solution. In clinical settings, particularly post-surgical rehabilitation, it's sometimes paired with oral medications as part of a broader recovery plan, the mechanical stretching and the pharmacological support working on different aspects of the same underlying vascular system. This combination approach reflects something important about the entire field of sexual health rehabilitation. It's rarely about finding one single fix. It's about supporting the same system from multiple directions at once. Let's pause here and talk about something that connects both of these methods, and honestly, most of modern health advice in general, and that's the uncomfortable reality of consistency. Neither pelvic floor training nor vacuum therapy works as a one-time intervention. They work the way physical therapy works, the way strength training works, the way cardiovascular rehabilitation works, through repeated, moderate stimulus applied over weeks, not days. This is often where good intentions quietly fall apart. A man tries something for 4 or 5 days, doesn't notice a dramatic shift, and assumes it isn't working. But vascular tissue, much like muscle tissue, adapts on a biological timeline measured in weeks, not sessions. Understanding this in advance is arguably more valuable than either technique itself, because it's the difference between quitting in week 1 and noticing genuine change in week 6. There's a psychological layer here worth acknowledging honestly. For many men, erectile difficulty carries a weight that has nothing to do with biology and everything to do with identity. It touches confidence, self-image, and how a man perceives his role within a relationship. That emotional weight often keeps men from seeking simple, evidence-based information, not because the information is hard to find, but because looking for it feels like admitting something. Yet the men who eventually do look into it often describe the same realization, that this is a physical health topic like any other, closer to managing blood pressure or cholesterol than to some deeper personal failing. Reframing it this way tends to lower the emotional barrier significantly, and that emotional barrier is often the biggest obstacle standing between a man and simple, low-risk interventions that could genuinely help. It's also worth connecting this back to broader lifestyle factors, because erectile vascular health doesn't exist in isolation from the rest of the body. Conditions like diabetes, high blood pressure, high cholesterol, and obesity all directly impact the same blood vessels responsible for erectile function, often years before any obvious symptom appears elsewhere. A sedentary lifestyle reduces overall vascular flexibility. Smoking damages the endothelial lining of blood vessels, directly interfering with nitric oxide production. Chronic stress keeps the nervous system in a state that favors blood vessel constriction rather than relaxation. None of these factors act alone, and none of them are meant to induce guilt. They're simply pieces of the same interconnected system. Improving general cardiovascular health through movement, through sleep, through stress regulation tends to support erectile function as a natural byproduct, not a separate project entirely. This is actually one of the more empowering realizations buried inside this entire topic. Because erectile function is so closely tied to overall vascular and cardiovascular health, working on one often means working on the other, whether that was the original goal or not. A man who begins walking daily to support blood flow to the pelvis is, at the same time, supporting the arteries feeding his heart and brain. A man who quits smoking to protect erectile tissue is simultaneously protecting against a dozen other long-term health risks. Very few areas of health offer this kind of compounding benefit, where addressing one specific concern quietly improves the entire system around it. None of this is about chasing perfection or treating the body like a machine to optimize at all costs. It's about paying attention to something that too many men have been taught to ignore, minimize, or quietly accept as an inevitable consequence of aging. Some decline in these functions naturally occurs with age. That much is biologically accurate and shouldn't be dismissed. But the gap between natural, gradual change and preventable, accelerated decline is enormous, and most of that gap is filled with modifiable factors, muscle tone, blood vessel flexibility, tissue oxygenation, cardiovascular fitness, none of which are fixed the moment you're born. If there's a professional consideration worth mentioning here, it's simply this. Persistent erectile difficulty, especially if it appears suddenly or worsens quickly, is worth discussing with a physician, not because it's shameful, but because it can sometimes be an early indicator of an underlying cardiovascular or metabolic issue that deserves proper evaluation. A pelvic floor physical therapist can also help ensure techniques like these are being performed correctly, since, like any exercise, form matters more than effort alone. Self-directed methods have real value, but they work best alongside informed medical guidance rather than in place of it. So where that leave us? Somewhere quieter and more grounded than most conversations about this topic tend to go. Not a promise of instant transformation, not a miracle fix, just a clearer picture of what's actually happening beneath the surface, and a reminder that the body responds to attention far more often than it responds to neglect. The blood vessels feeding every part of you, including the parts nobody talks about at dinner, are shaped by the same daily choices that shape the rest of your health. Movement instead of stillness. Awareness instead of avoidance. Consistency instead of quizzes. Maybe the real shift here isn't learning two specific techniques. Maybe it's realizing that this part of the body was never separate from the rest of your health in the first place. It was just treated that way, hidden behind discomfort and silence for far too long. And once you stop treating it as separate, you start treating it the way you'd treat any other system worth taking care of, with patience, with consistency, and with the quiet understanding that small, repeated attention is usually what changes things long before anything dramatic ever does.